Good evening, sir.
Hi, good evening.
Hello, good evening, everyone. Good evening. Thank you for joining. Thank you. So we'll be starting in a minute or so, and
Okay.
we have gone on YouTube Live now.
Good evening, sir.
Good evening.
Hello, good evening, one and all.
Good evening.
So good evening, everyone, and we will be starting now.
Good evening. Thank you for joining. Thank you.
So it gives me immense pleasure to welcome you all to this insightful webinar on allergy immunodeficiency crossroads. On behalf of IAP Allergy and Applied Immunology chapter, and in collaboration with our colleagues from the Primary Immunodeficiency and Inborn Error of Immunity chapters, I extend a warm welcome to our esteemed speakers, panelists, and attendees from across the country. This webinar addresses an area that is often under-recognized but critically important: how primary immunodeficiency disorders can mimic or overlap with allergic diseases. As pediatricians and allergists, we are frequently challenged with differentiating persistent or atypical allergies from underlying immune dysfunction. A nuanced understanding of these crossroads is essential for timely diagnosis, appropriate referral, and effective management. Today's session is a testament to the power of collaborative learning. It brings together the expertise of allergists, immunologists to shed light on clinical dilemmas, share best practices, and enhance our collective ability to serve patients better. Let us use this platform to ask, learn, and discuss freely and carry forward the momentum of integrated multidisciplinary care in our allergy daily practice. With that, I will invite Dr. Manas Kalra, Senior Consultant at Sir Gangaram Hospital at Department of Pediatrics, to moderate the session along with Dr. Amit Rawat. Dr. Manas, you are welcome, and please introduce Dr. Amit and start the session.
Good evening. Good evening, everyone. It's a big honor for me and Dr. Amit Rawat, both of us, to uh, welcome all of you to this session. Dr. Amit Rawat and myself represent the Immunodeficiency chapter and the Pediatric Hematology Oncology chapter of Indian Academy of Pediatrics. We all know that in the last few years, there has been a big revolution in the field of immunology. And thanks to the new training programs, thanks to the available investigation modalities, thanks to the evolving science of stem cell transplant, that all of this put together has led to great improvement and great strides in the diagnosis and management of immunodeficiency disorders. I really thank Dr. Neeraj Gupta, who gave us the opportunity to join hands together and present this webinar to all of you. I hope it is useful for everyone who is participating live and who is also on YouTube live listening to this session. And we have very esteemed speakers today who will be taking you through various aspects of primary immunodeficiency. Dr. Amit Rawat is a very senior, well-known faculty from PGI Chandigarh, one of the teacher of teachers, and has done immense work in the field of immunodeficiency, especially in the lab diagnosis of these rare disorders. And I'll now like Dr. Amit Rawat to say a few words and then introduce our first speaker, and we can move on with the session from there on. And we'll have the questions at the end of the session. So Dr. Amit Rawat, sir, please.
Thank you, Dr. Manas, for the kind introduction. And welcome everyone to this joint effort. And it's also quite, useful because patients with inborn errors of immunity, they can present with malignancies, atopies, or even autoimmunity. So it's like, there are like blurring boundaries between these actually in that sense. So it's useful that the three chapters, the Indian Society of Primary Immunodeficiency, the Allergy chapter and the Hemonc chapter of the Indian Academy have joined hands to do a joint webinar. And I really appreciate the efforts for this joint webinar. And I do welcome this and maybe some more future activities of this kind. So with that, I would like to, since we are on a very tight schedule, I would like to welcome my junior colleague, Dr. Vignesh Pandirajan, who is a additional professor at the Pediatric Allergy and Immunology Unit at PGI Chandigarh. And he would be talking about the clinical aspects of these primary immunodeficiency diseases, which are also now known as inborn errors of immunity. Over to you, Dr. Vignesh.
Thank you, sir, for the kind introduction. And let me see if I'm able to share my screen. Okay, I'm having problem. Yeah, now I'm able to share my screen. Yeah. Okay, so I hope my screen is visible now.
Yes, it is visible, Vignesh.
Okay, thank you. Okay, thank you, Dr. Neeraj Gupta, Dr. Manas Kalra, for bringing us all together for this webinar. So let us start quickly. So I'm Dr. Vignesh here to present the clinical presentation of a child with PID in practice. So let us start with a case example. So this is a gentleman, 20-year-old gentleman who came from Gujarat, Western India. He came with a bunch of investigations that he has been investigated for the last 15 years for several complaints. He has been seen by multiple pulmonologists for multiple episodes of pneumonia and interstitial lung disease, seen by gastroenterologists for recurrent episodes of diarrhea. He Googled the symptoms himself and he came out with a diagnosis that he may probably have a common variable immune deficiency. And that is the diagnosis he had. So the subspecialists have been doing wonderful job in looking after the symptoms what he had, but the common main etiology for all his symptoms were the common underlying immunodeficiency. His serum immunoglobulins revealed the diagnosis. So this is common variable immune deficiency. So just to give you another flavor, so the left panel shows a 14-month-old boy who came with pyoderma, recurrent pneumonia, and pneumothorax. His father, you can observe that his faces doesn't look okay. He had little bit of coarsening. You can see he has bushy eyebrows, a very prominent nose. So he has also been ill since his early childhood, recurrent episodes of skin abscesses and repeated episodes of pneumonia. So this is the classical presentation of autosomal dominant STAT3 dominant negative hyper IgE syndrome, recurrent Staphylococcus aureus. So this is one immunodeficiency which presents with phenotypic abnormalities. So the face will give you the answers here. So if you see here, so this is the evolution of the coarsening of the faces. In the early age, it may not be that visible, but over the age, the prominence of the bushy eyebrows and more coarsening would happen as the age progresses. So this is one another child. You can see the synophis. So this is one another characteristic abnormality and the prominent philtrum and the retained dentition. So most often the X-rays can give you the clue. So X-rays would show you the retained primary dentition. So overall, so to identify a PID, so this is a three-pronged approach. So the first thing important here is the age of presentation. So this is the common teaching. Generally, the cellular immune defects present before the 6 months of age and humoral immune defects present after the 6 months of age. This is due to the maternal IgG, which is there in the circulation, which is present in high concentrations in the initial 6 months that takes care of encapsulated organisms. And after 6 months, the maternal IgG wanes off. The body has to produce its own immunoglobulin. And if you don't produce that, you'll end up in having encapsulated bacterial infections. So that's how the humoral deficiency presents, so usually presents after 6 months. So generally, if we see the manifestations, if you see in the first few weeks or months, it is the combined immunodeficiencies, the severe combined immunodeficiencies, which presents in the early infancy. Severe congenital neutropenia. Neutrophils are very important first line of defense for Staphylococcus aureus and fungus. Digeorge syndrome, if it is complete Digeorge syndrome, you can have complete athymia, and they can present similar to severe combined immune deficiency, leukocyte adhesion defect. So these present in the early infancy age group. If the presentation is between the 6 months and 5 years, it is the usual XLA, the Wiskott-Aldrich, and the phagocytic defects, such as chronic granulomatous disease. If it is more than 5 years, it is generally the common variable immune deficiency and antibody deficiency groups that come up, also the complement disorders and ataxia telangiectasia. So the second is the type of organisms, which gives you the clue. So in SCID, generally what you get is the opportunistic infections, what you see similarly in HIV-infected children, like Pneumocystis jirovecii, mycobacterial infections, cytomegalovirus, bacteria. So they present with failure to thrive, oral thrush, pneumonia, and diarrhea. Whereas in XLA or an early complement deficiency, so the immunoglobulins and early complements, these are very essential for clearance of encapsulated bacterial infections. So that's why you get more of Haemophilus influenza, Streptococcus pneumoniae, and X-linked agammaglobulinemia. Also, the important parasitic infection, the Giardia lamblia, infestation of the duodenum, they present with persistent diarrhea. And enteroviruses, they can land up in difficult encephalitis due to enterovirus and oral poliovirus vaccines. So this is the infection spectrum of antibody deficiencies. If you see phagocytic defects, especially chronic granulomatous disease, it is generally the catalase positive organisms. So here you get a different set of organisms, that is the Staphylococcus aureus, Serratia, this is the community acquired Serratia, Aspergillus, community acquired, Candida. So they land up with persistent pneumonia or a deep organ abscesses, suppurative lymphadenitis, and skin infections. Complement defects. The late complement defects presents with Neisseria infections, whereas the early complement deficiencies, as I've already told you, presents with the encapsulated bacterial infections. Should also remember that lupus syndromes are an important clinical presentation of early complement deficiency. Hereditary angioedema, I would not be touching in my talk today, but it's also a C1 inhibitor deficiency, which comes under the complement deficiency group. So let us take you through a case example. So this is a 6-year-old girl with multiple lactic bone lesions. Her HIV was negative. You can see punched out lesions in the skull and in the bones. So thought to be LCH. You can see punched out lesions in the right upper humerus. The FNAC gave the clue that this is a granulomatous inflammation with multiple acid-fast bacilli. And culture, it is the Mycobacterium bovis. So Mycobacterium bovis doesn't really disseminate like this in any immunocompetent kid. So this is definitely an underlying immunodeficiency. And this is a selective predisposition to Mycobacterium bovis. So what do you rule out? So you look at CD subsets because combined immune deficiency is present with Mycobacterium bovis. It is normal. You do a NBD-DHR because chronic granulomatous disease can sometimes present with BCG dissemination, not usually. So these are simple immunodeficiencies to rule out. So these are negative. So what we are dealing here is a Mendelian susceptibility to mycobacterial disease. And this patient has a partial dominant type of indifferent gamma R1 defect, which is subsequently proven by flow cytometry and molecular analysis. Okay, so we looked at the age of presentation, type of organism. Now, the third important aspect in PID is the family history. So X-linked recessive disorders, these are very few, so you can easily remember. So the severe combined immune deficiency, especially the IL-2 RG defect is X-linked agammaglobulinemia, the CYBB defect and chronic granulomatous disease, X-linked hyper IgM syndrome. So these are X-linked recessive disorders. Autosomal dominant disorders are also very few, the STAT3 dominant negative hyper IgE syndrome, the hereditary angioedema, the C1 esterase inhibitor, the autosomal dominant IFN gamma R1 defect or STAT1 gain of function, loss of function. So these are autosomal dominant disorders. So it is very, very important to take a family history. So it will give you a clue. So this is just a administrative block in PGH Chandigarh. Okay, so this is a 4 months-old boy who's failing to thrive and has an oral thrush, and this is the X-ray. So you can see that the thymus is absent, and you can see an interstitial infiltrate. So this is pneumocystis pneumonia, and this is the hemogram. So what you see here is a normal TLC and anemia. In the differential counts, it is very important to pay attention to the lymphocyte percentage. So the absolute lymphocyte count is very low. It is just 900 in this patient. So this is a classical presentation of a severe combined immune deficiency. So you just recognize at the bedside, this child has an oral thrush, pneumonia, and lymphopenia. So there is hardly any differential diagnosis. You confirm it by doing a flow cytometry and a molecular analysis. So this is an X-linked kid. And this is a 4-year-old boy who came with a failure to thrive, recurrent pneumonia after 6 months of age, and he landed up having an arthritis. So this is a prototype presentation of what we call as X-linked agammaglobulinemia. So this is the immunoglobulin profile of this child, which shows pan-hypogammaglobulinemia. There are hardly any immunoglobulins. And lymphocyte subset shows an absent B cell, and you can confirm it by molecular diagnosis. But what is more important is the suspicion and sending the immunoglobulin profile. Okay, so this is the absent tonsils, which you can see in this patient. So a close examination of the lymph nodes and the tonsils, these are very important. So this is a 6-year-old boy with non-resolving pneumonia, treated for tuberculosis twice, CT chest revealing the right lobe pneumonia. In the FNAC, you get two fungus here, Candida and Aspergillus, and this is the prototype presentation of chronic granulomatous disease. You can confirm it by a NBT reduction test and a dihydrorhodamine assay, and subsequently genetic studies confirm the same. So the more important aspect here is the evaluation of pneumonia. So just because a child is running on with a persistent pneumonia, empirically starting ATT is not the answer. It has to be seen what is the underlying etiology. So moving forward, so these are the typical clinical pictures of chronic granulomatous disease, the non-healing scars, BCGitis, localized BCGitis is very common in chronic granulomatous disease, liver abscess, and the perianal sinuses. So these are typical. If any child presents with this combination of spectrum, it's nothing but a chronic granulomatous disease. So the clinical presentation, as I already told you, recurrent lymphadenitis, BCGitis, persistent pneumonia, usually fungal, deep organ abscesses, such as lung or liver abscess, osteomyelitis, especially the small bone osteomyelitis or a vertebral osteomyelitis. So this is the importance of a family history. So this is what we got in a child with presentation of a hemophagocytic lymphohistiocytosis. It's a typical X-linked history. So multiple male siblings have, the family has lost in the early infancy due to some infections, some blood-related problems. So this child who presented with HLH turned out to have an X-linked CGD who presented as a hemophagocytic lymphohistiocytosis. So non-healing ulcers, this is the typical feature of either neutropenia or a leukocyte adhesion defect. Here, if you see the CBC, it is of sky-high TLC with polymorphonuclear predominance. The differential diagnosis is nothing but a leukocyte adhesion defect. So if you see this kind of presentation, this is the child you should work up for type 1 LAD. And again, pyoderma gangrenosum. This is a 12-year-old boy who presented with these kind of lesions, non-healing pyodermas. So this is again a leukocyte adhesion defect, a hypomorphic form. Moving on. So this is a 4-year-old boy with eczema and petechiae. So what I'm trying to emphasize here is the peripheral smear, which is showing low platelet count, also small platelets, because it is very important to examine the peripheral smear in these patients, because the Coulter mean platelet volume would not be a much reliable assay in the Wiskott-Aldrich. So a fresh peripheral blood smear is very essential. So this is nothing but a Wiskott-Aldrich syndrome, can be confirmed by a flow cytometry. You should remember that the spectrum of Wiskott-Aldrich is varied, so they can present just with thrombocytopenia, which is called X-linked thrombocytopenia. On the other end of spectrum, you have a full-blown combined immunodeficiency presenting with severe infections, autoimmunity. So the typical triad is the atopic dermatitis, infections, and thrombocytopenia. But you should remember thrombocytopenia alone can be a presentation of Prescott-Aldrich, which is very important in males who have persistent thrombocytopenia. So as pediatricians, we need to think beyond infections, beyond sepsis, and we should remember that PIDs can be diagnosed even in the context of resource-limited settings. So as Professor Rawat has told in his initial introductory talk, that it's not infections alone, can have allergies presenting as a PID, autoimmunity, hyperinflammation, which is autoinflammatory disorder, and even malignancy or lymphoproliferation. So PIDs, they can present with multiple aspects of these. Importance of identifying underlying PID is you can have mechanism-based treatment strategies or tailored therapy for these patients. So I would just want to highlight this one seminal paper published in Journal of Allergy Clinical Immunology, which says that autoimmune and inflammatory manifestations occur frequently in patients with primary immune deficiencies. So around 26% of these patients of 2,183 patients had one or more autoimmune or inflammatory complications. Important thing to highlight here is the risk of autoimmune cytopenia was 120 times higher than in the general population, and risk of inflammatory bowel disease was 80 times higher in PIDs. So overall, if you see the common variable immune deficiencies and combined immunodeficiencies, they have a very high rates of autoimmune cytopenia. The innate deficiencies like CGD or other innate immune deficiencies, they have very high rates of inflammatory bowel disease. So pediatric events, because we have pediatric hemato-oncology chapter here, it is very important to highlight the pediatric events is associated with a high frequency of early onset PIDs. So here they have sequenced and done functional evaluation of 203 patients with early onset Evans syndrome, and 65% have had a genetic diagnosis. And so these are PIDs, nothing but PIDs, immune regulatory disorders. So the genetic findings have a prognostic significance and may guide the physician's choice of targeted treatment. So these are the 10 warning signs given by the Jeffrey Model Foundation for pediatric age group. So these are mainly infection predominant. If you see all the 10 warning signs, they are infection predominant. So I think we should also suspect PID in early onset autoimmune cytopenia, early onset inflammatory bowel disease, and early onset lupus. So to sum up, primary immune deficiency disorders, they are not uncommon in clinical practice. Diagnosis is essentially clinical, and pattern recognition is the essence, and do not miss the forest for the trees. So with this, I conclude my talk. So thank you again.
Thank you, Dr. Vignesh, for such a fantastic presentation. You know, within a time, you have finished the essentials of clinical presentation of patients with PID, and I think you gave some very valuable tips to all the pediatrician colleagues, PHO people, and people from the allergy chapter and from the immunodeficiency chapter. So once you suspect primary immunodeficiency by this myriad of uh, clinical features, you know, not only infections, autoimmunity, malignancy, importance of family history, and the age of onset and the pattern of infections, if you put all these things together and just with simple basic investigation, you will be able to diagnose immunodeficiency in most of the cases. So we now move on to the second aspect, which is the lab diagnosis of immunodeficiency. You know, often a pediatrician or a allergy specialist or a hemong person, whenever they see or suspect a immunodeficiency, they'll be perplexed as to how can I make a diagnosis? What all investigations can we do? And, you know, do we have to just immediately refer this patient? Or at our primary center, can we do some basic evaluation and, you know, make a clinical and a lab diagnosis of, or at least give a direction to the patient as to which way we are dealing with? So for this very important topic, we have very bright young scientist with us, Dr. Umair Bagir. He's a clinical scientist in the Department of Pediatric Immunology at ICMR. very helpful person. He's always helped us with very difficult diagnosis for many patients. He works at the prestigious National Institute of Immunohematology in Mumbai, and he has a special interest in genomics and immunogenomics. He's one of the young, bright champs of the field of immunodeficiency in India. So, Umair, you now have next 15 minutes to take us through I know that the topic is very huge, but I would request you to take us through the diagnosis of immunodeficiency in a simplistic way for our audience. Thank you.
Thank you, sir. At the outset, I would like to thank the organizers. So when we think about lab diagnosis in inborn errors of immunity, conventionally what comes into our mind is flow cytometry. But today I would like to deal the gen alpha way. So as you all know, that though most of us are millennials, I saw some of the names who are probably Generation X or baby boomers, but almost all of our patients are Gen Z and Gen Alpha. So we need to think about the Gen Z and the Gen Alpha way. That is the era of the exome sequencing and the whole genome sequencing. When we look at the history of DNA sequencing from the early 1950s to 2020s, there has been a marked exponential growth in the field of genomic sequencing, where the quality of the data is improved, whereas the cost of sequencing has reduced. So when the first whole genome project came, it costed millions of dollars. But now we all in India can have a very ease of access to next generation sequencing, where we can now get the exome sequencing for around $150 and genome sequencing for around $600. But now in the when we have entered the fourth generation of sequencing, we now will be able to achieve whole genome sequencing for a cost of only $200. So why do we need to think about the exome and the genome sequencing first? What is the need for next generation sequencing? The diagnosis, as has beautifully been explained by Dr. Vignesh, is based on the clinical and the immunological abnormalities. But the cases are not that simple. Conventionally, we are taught that there is one gene and one disease. But when we deal with immunodeficiencies, we all know that one gene can have many phenotypes and many genes can have one phenotype. And that is the need where next generation sequencing takes care of these problems to an extent. So we can appreciate the exponential growth in the number of genetic diseases that have increased over the years, where the first initial first primary immunodeficiency was described in the early 1950s to 485 monogenic different diseases in 2022. And in the last week, now we have the latest classification of 2024, where we have 555 distinct monogenic diseases. But for the sake of ease, the International Union of Immunological Societies, they have classified all these diseases into 10 different categories based on their clinical presentation. So once we think about once we suspect immunodeficiency, it becomes comparatively easy to place these differentials and to prioritize the diagnosis accordingly. So what I would like to do is I'll be covering the clinical aspect has already been covered. And when we think of the different categories of inborn errors of immunity, what can be the approach and how do we diagnose these diseases, so that I can at least try to touch upon how we can think about diagnosing these more than 500 distinct diseases. So just a brief as to whole exome sequencing is the one that we conventionally do. Whole exome sequencing covers all the entire exonic region. Most of us are aware that in the past couple of years, we used to do something called as clinical exome sequencing, where the genes of clinical relevance, only they are sequenced. And the reason why it was being done was the cost was less for the commercial companies. But now, since the cost is almost equivalent to whole exome sequencing, people are conventionally doing whole exome sequencing. Whole genome sequencing has use in research application, but for clinical application, because the cost is still an implication, a conventional 30x whole genome sequencing will cost more than 50,000 rupees. It is not preferred, and it is usually done in research-based settings. So if we look at the 2024 update of the IUI's phenotypic classification, I would like to spend some time on this slide. in the background of infections, and once we know what is the spectrum of pathogen, is it a broad spectrum pathogen? Is it a narrow spectrum pathogen? Like, for example, you have only bacterial infections, or you have fungal infections, or mycobacterial infection. This diagram helps us to go to the particular category of inborn error of immunity and help in prioritizing the differential diagnosis. As Dr. Vignesh has beautifully summarized in his last slide, it is not only infection, it is the autoinflammatory component, the lymphoproliferative component, the non-immune syndromes, that are the neurological disorders, neoplasias, MDS. If suppose these are also present, how do we approach these patients? And this is beautifully given in this International Union of Immunological Societies classification. So what are the basic investigations that help us in diagnosing these patients? We have the CBC, the peripheral blood smear, the lymphocyte subset analysis that we call as the T cell, B cell, and NK cells, the immunoglobulin levels, and the nitrobiotetrazolium test. These are available in many centers. CBC and peripheral smear are available in all centers. And nowadays, lymphocyte subsets, NBT, and immunoglobulin are also available in most of the centers across India. Apart from that, we have the liver function test that will, in a way, help in suspecting a few select disorders. The blood culture to know what pathogen we are dealing with. The direct Coombs test if we are dealing with a case of autoimmune hemolytic anemia or Ivan syndrome. The CRP as to what kind of infection. We have this for the triglyceride, ferritin, fibrinogen, the coagulation profile. When we are thinking about hemophagocytic lymphohistiocytosis, the basic simple chest X-ray as to what is the type of pneumonia, is it recurrent, same site, same, is it on the same side, is there a thymic shadow, HRCT scan. All these basic tests are helpful in ruling out common diseases and give us a clue about underlying inborn error of immunity. It is very important to rule out HIV because these are secondary immunodeficiencies that are more common as compared to primary immunodeficiencies. And EBV, which is a very notorious virus leading to EBV LPDs and responsive, and there can be an underlying inborn error of immunity. So this is the report that we see day in and day out, and we have the common WBC count, the neutrophils, lymphocytes, eosinophils. Eosinophils are helpful when we are suspecting hyper IgE syndrome, monocytes if there is monocytopenia and we are suspecting a monomax syndrome, and hemoglobin if suppose there is hemolytic anemia. So basic simple CBC gives a very important clues as to whether there is neutropenia, whether there is marked neutrophilia, whether there is lymphopenia or there is lymphocytosis. These things give very important basic clues to the underlying inborn error of immunity. And of course, the platelet count, once we think about immunodeficiency and platelet count, when there's thrombocytopenia, we know what disease we are thinking about, right? So, as I said in the beginning, flow cytometry is the one that is the most important test that is used routinely for diagnosing inborn errors of immunity. And the common one is the lymphocyte subset analysis. So conventionally, what we look in the lymphocyte subset is the T cells, the B cells, and the NK cells. The T cells have two components, the helper T cells and the cytotoxic T cells, right? And we all know what are the different markers. But at NIH and at many other centers now, what people are doing is they are doing an extended lymphocyte subset analysis. So what is extended here? Here, apart from these basic subsets, now we are also looking at the naive T cell and the memory T cell component and the memory B cell component. So these are very helpful in diagnosing severe combined immunodeficiencies. So these are the plots from a severe combined immunodeficiency child where you have marked lymphopenia. You can appreciate the absence or very reduced number of T cells in these patients, but the B cells are present. So this is a case of a B positive, NK positive skin. If all cells are markedly low, it can be a T negative, B negative, NK negative skid. If only NK cells are seen like this, then it can be case of NK positive skid. But we need to ink them with caution because these can be transient lymphopenia. How we do we
I am
differentiate
Pani
transient?
teacher.
How do we differentiate transient lymphopenia from a severe combined immunodeficiency case? We need to do the naive and the memory T cell component. So the primary immunodeficiency treatment consortia 2022 has given a beautiful definition, beautiful guidelines for diagnosing SCID, and the naive cells are the easiest, especially in the absence of TREC assay, that is the newborn screening, which currently is not being done in India. Apart from that, we have the HLA-DR expression that we do, and it is very helpful to diagnose MHC class 2 deficiency. Also, if it is abnormally high on T cells, it can be because of Omen syndrome or leaky SCID phenotype. Now, moving on to the separate categories, there are 10 categories. So what I would like to do is that if we take this category, what are the common tests available across multiple centers, and what are the specialized tests available which can be used in these patients? So when we are thinking about combined immunodeficiencies, based on the basic lymphocyte subsets, you can appreciate the classification. The P positive, the NK positive, the NK negative, though not very sensitive, but it is helpful to a great extent to pinpoint the underlying genetic etiology. Why is it important? Because our transplant physicians will help us, will tell us how it may alter the treatment, alter the transplant, the conditioning regimen or so. If it is a case of if it is a case of radio sensitive SCID, some things are to be taken into consideration. So the commonly available tests are the 6-color lymphocyte subset, which is available in almost all the flow cytometry centers across India. The naive T cell subset, if the machines are of lower configuration, it can be customized to look only at the basic naive T cell subsets. And many of the centers now are doing extended lymphocyte subsets with or without the HLA-DR expression, because of commercial tubes that are now, dry tubes that are now available in India. Apart from that, when we are thinking about combined immunodeficiencies, T cell proliferation is very helpful, especially against different stimuli. Like we have very strong stimulus, that is PHA, or we may have anti-CD3, anti-CD28 and other stimuli that can be helped to assess whether the T cells have proliferative capacity or not. If there is a clonal expansion, then V beta repertoire can be helpful. We have special protein expression, special protein assays based on the underlying genetic etiology that can help to confirm the variants of uncertain significance that we often encounter in our next generation sequencing reports. And in the case of severe combined immunodeficiencies, we can assess the phosphostat 5 expression, especially for the B positive SCID, to confirm our diagnosis. TREC assay is selectively available in few centers, but since we are not doing it for newborn screening, we may rely on the naive T cell subsets to get that information. When we think about the combined immunodeficiencies with syndromic features, here we think about the congenital thrombocytopenia, and we all know what disease comes into our mind. We have DNA repair defects where there is an increased radiosensitivity and chromosomal instability. Immunoosseous dysplasias are there. Then in that's the subcategories of the thymic defects with other congenital anomalies, anhydrotic ectodermal dysplasia or the Nemo syndromes, the hyper IgE syndrome. When conventionally we think of hyper IgE syndrome, it is not only one gene, it is not only STAT3 loss of function. There are multiple genes that are responsible. So even if we think that we'll do STAT3 expression by flow at the outset, we may miss other genes. So it is always better that we upfront get exome sequencing also done, because nowadays the turnaround time is also very fast. If wanted, we can get a NGS report within a week also. The defects in B12 deficiency and folate metabolism are also responsible for different inborn errors of immunity. And of course, the syndromic features with the neurologic complications like the ataxia telangiectasia. So like the previous category without syndromic features, these patients have syndromic features along with T cell and B cell defect. So again, the assays will remain the same. The naive T cells are very important to say whether the lymphopenia is transient, whether the T cells, the naive T cells are absent and they don't have any proliferative capacity, which immediately helps us diagnose that, okay, this patient is combined. We need to involve transplant physicians to begin with so that it can help the patient down the lane. T cell proliferation assays are again very important here. The one common difference between combined without syndromic and with syndromic is the degree of lymphopenia is comparatively milder here. So on a basic lymphocyte subsets, it may be missed. That is why these advanced assays need to be done. The commonest category, when we look at this peripheral smear, you can appreciate the small platelets, and the disease that comes into our mind is the Wiskott-Aldrich syndrome, right? It's a combined immunodeficiency with syndromic features. So the mnemonic that we can remember is Wiskott-Aldrich whiskey. And how is it a mnemonic? So basically the IgE and the IgA levels are up. So when we drink ethyl alcohol, the E and the A level go up, and the mental function and the growth goes down. So the IgG and IgM, if they are low, if there's thrombocytopenia, we may think about Wiskott-Aldrich syndrome. The commonest symptomatic inborn error of immunity is the antibody deficiency disorders. So here these patients have hypogammaglobulinemia, and these patients, here we can do lymphocyte subsets, B cell panel can be done, and there are specialized functional assays like BTK, mTOR, apoptosis assay, IgG subclass, specific antibody response that can be done to diagnose these patients. And isohemagglutinin titers, the NT and the NTB titers, they can easily be done in the blood banks, and we should take their help to get these. The serum globulin concentration can also give an important clue, especially if serum immunoglobulin levels are not done. We can look for the serum globulin levels, and these cutoffs, the cutoff of less than 1.8 or 18 G per L can help in diagnosing these patients. When we think about hemophagocytic lymphohistiocytosis, we all can do these basic investigations in all our hospitals. We can do a hair mount if there's an albinism. The peripheral blood smear can also help to appreciate granules in cells. And then there is a perforin assay and CD107A NK cell degranulation assay that is abnormal in familial HLH, both with hyperpigmentation and without hyperpigmentation, FHL2 to FHL5. So these are the different scores and classification for HLH. 2024 is also come, and these basic investigation can help us diagnose them. These are the flow cytometry plots for the perforin expression and the degranulation, the granule release assay. When we think about autoimmunity with immunodeficiency or immune dysregulation, the worst thing that comes into our mind is autoimmune lymphoproliferative syndrome, right? So basically, these are non-Treg defects. Here, the double negative T cells are elevated, and they can easily be appreciated even on a basic 6-color assay. If the double negative cell population is more than 10%, it must ring the bells, and we must do the sensitive TCR alpha beta test so that the double negative T cells are characterized. There are special assays that can help distinguish the fast controlled double negative T cells and the other T cells. Then apart from that, we have Treg defects, the regulatory T cell defect, who have very severe autoimmunity, and LRBA expression and LRBA defect and CTLA4 defect. They are also comparatively more commonly being diagnosed because of the ease of NGS. The problem being the variant of uncertain significance, and specialized assays for the protein expression by Western blot or CTLA4 expression by flow cytometry can help. If the patient has early onset diabetes in the background of multi-organ autoimmunity, CD25 deficiency can be suspected. When we think about the phagocyte numbers, we have the common congenital neutropenia. When we encounter a variant of uncertain significance in discussion with the hematology colleagues, when we look at the marrow finding, look at the stage of maturation arrest, the variants of uncertain significance, special functional assays can be carried out in select cases based on the underlying genetic defect. When we think about the other functional defect, we have the common chronic granulomatous disease, as was discussed by Dr. Vignesh, where we can do the nitroblue tetrazolium test, the DHR component. Here, the thing with the P47 or the NCF1 gene is it has a pseudo gene, and which cannot pick up the del GT mutation commonly by an exome sequencing. So we can easily get a flow cytometry expression for P47 and do a gene scan for confirmation. For the mature neutrophil, the CD18 and the CT11 ABC can easily be done for leukocyte adhesion deficiency, where this expression is low or absent. These are the mature neutrophils from a peripheral blood smear of a LED patient. When we think about intrinsic and innate immune defect in a background of viral infection, the biopsies, viral PCRs are very important. And then depending on the case, so since it's a vast spectrum of genes, there aren't many functional assays available upfront. But if we know the genetic etiology, functional assays can be planned pertinent to that gene and it can be done. The second commoner category is the predisposition to bacterial infection, the Mendelian susceptibility to mycobacterial disease or MSMD. Here, we can perform different functional assays by flow cytometry, but it will cover only 6 genes. There are many other genes. So when we are suspecting MSMD, again, we need to think about doing an exome sequencing simultaneously. It should be done along with these functional assays so that we reach the diagnosis fast, because the management will depend on the underlying genetic etiology. When we think about autoinflammatory disorder, it's a mixed basket where we need to involve our rheumatology colleagues, ophthalm colleagues, neuro colleagues, and dermatology colleagues, because these patients present with inflammatory complications, have recurrent fever, can have systemic manifestation. So here the special investigations that can be done are the interferon gene signature, which also are helpful in SLE cases. So these can be done, different cytokine panels can be done, and Siglec expression by flow cytometry can also be done, so that we can evaluate whether the variant of uncertain significance that is identified on an exome sequencing, is it having any significance or there is some other genetic etiology to it. When we think about complement deficiencies, they can have either the infectious phenotype or the non-infectious phenotype. And if we are dealing with a disseminated Neisseria infection, then there's a list of genes. If there are only pure bacterial infection, bacterial meningitis, pneumonias, then there is another list of early complement deficiencies. The non-infectious phenotype, we have SLE-like syndrome and atypical HUS. So the commonly available assays, the basic investigations can be done along with CH50 and AH50. The one thing that needs to be taken into consideration is complements are heat labile. If we are doing it in commercial labs, please do make sure that the sample reaches in -20 or -80. We send a frozen serum sample and the test has to be performed on that. If it is not performed, we may get spuriously low values. So to summarize, there are 4 stages of inborn errors of testing for primary immunodeficiencies. In the background of clinical evaluation, we may get immunoglobulin levels done, the specific antibody response, the subclass done, then the lymphocyte subsets, the NBT, complement deficiencies, and then the family or genetic studies. But with the ever increasing spectra of inborn errors of immunity, we need to think about doing an exome sequencing simultaneously with these basic investigations. So thank you.
Thank you, Mayor, for this, elaborate presentation on diagnosis of PID. It is a little complex, but I guess the basic message you have conveyed it very clearly, that what are the basic evaluation that anybody can order, and then there are all those advanced tests that you will need a reference laboratory to actually help you to carry out those investigations. So, after you have made the lab diagnosis of PID, to explain to all the participants, I think we now need to go back to our main subject today, where the allergy, the PHO chapter, and the immunodeficiency chapters are coming together. Why? Because allergy in this world is becoming so prominent, and which are the patients with allergy where immunodeficiency can be a underlying disorder, or is allergy and immunodeficiency two aspects of the same spectrum? So to highlight that, we have a senior pediatrician from Bangalore, an allergy specialist, Dr. Soumya Nagarajan, who will be speaking on child with PID masquerading as allergy as the next topic. Thank you, Dr. Soumya, for joining us. And we are very eager to understand the how on these crossroads a pediatrician, a pediatric hemonc person, or an allergy or an immunodeficiency specialist can suspect PID in these patients.
Thank you, sir. Thank you for a very kind introduction. And at the outset, I would like to thank Dr. Neeraj for involving me, along with the esteemed panel of speakers we have heard earlier today. And I would like to share my screen next. To get a allergist perspective, I have tried to put it across from a pediatric allergist perspective, and probably it's a very basic presentation as compared to what the ground has been said by Dr. Vignesh and Dr. Umer. I was fortunate enough to spend a few weeks when I came back from Singapore in PGI immunology and rheumatology department. And it's the amazing work they do. I think they have set the bar very high. And from an allergist perspective, when we talk about patients, I mean, kids who are being referred frequently for this patients are mainly on recurrent infections. And basically, as highlighted by earlier speakers as well, it could be a normal child or children who could be presenting with an underlying atopy or other chronic conditions or inborn errors of immunity. So in at least approximately 30% of children who presents with recurrent infections, being the age of presentation of the family history, which is important as highlighted by Dr. Vignesh, 30% of them could have an underlying atopy. Most of the patients whom we get referrals, most commonly it could be a chronic respiratory diseases, which could be a chronic allergic rhinitis, they would be thinking. And these children are also managed as asthma and put on the MDIs for the same. Or they tend to get sometimes skin infections, skin diseases, such as hyper IgE, Omen's, or viscotilde syndrome, where we could see eczema as one of the predominant feature, but they also have other leading signs as well. So let's start off with the case scenario where this was a 2-year-old child who had frequent ear infections, one documented bacterial meningitis in the first year of life. But the more predominant symptoms were cough and cold, recurrent episode in the recent few months, where the child has been treated as wheeze-associated lower respiratory infection and was treated with multiple nebulizations and put on inhalers, some steroids. The family history of atopy was strongly present, and there were no pets at home or an exposure to environmental tobacco smoke. There was unremarkable birth history, and on examination, the child's weight was on the 3rd centile, height was on the 10th centile, respiratory system was unremarkable, and there was no organomegaly. However, adenoids, I mean, there were no other features which could be contributory to his respiratory infections, which we think of adenoids in the that age group. And he was treated with nebulizations for recurrent cold and cough, as we said. Because I think the salient features which has been highlighted in the earlier presentation, this child had failure to thrive and a very unremarkable atopic history, except for the family history. And I think allergy was a little lower down on the list. As highlighted, even a basic workup could be done. And in this patient, the immunoglobulins level done were very low, below the reference ranges, and there was no specific antibody response after the vaccinations. However, the basic T cell subsets which were done were normal. And as highlighted in the talk by Dr. Umer about the laboratory diagnosis, CD19 is mainly a marker of the B cell, whereas the CD3 is a marker of the T cell. differentiation. In this patient, we had remarkably no absent B cell differentiation at all. So this was a patient who had X-linked A gamma globulinemia, and these patients are more susceptible to pyogenic infections, mainly mycoplasma arthritis, viral meningoencephalitis, and recurrently they present with infancy or childhood cyanopulmonary pyogenic infections. So predominantly it's an X-linked disorder, and a very common scenario where it is mistakenly presenting as an atopic disorder, mainly a respiratory allergic disorder, and we continue treating this patients with appropriately with pharmacotherapy for that particular condition, but with minimal response, as we saw in this child. So I think having a high index of suspicion where red flags should be considered, like failure to thrive and unusual infections, I think we can do basic investigations and probably refer them to a primary immunodeficiency center. So other antibody deficiencies could be hyper IgM, common variable immunodeficiencies, IgG subclass deficiencies, and transient hypogammaglobulinemia of infancy. So we also had published this paper on common variable immunodeficiency. This was in an adult, where he had presented with diarrhea, which has been a predominant symptom, and also recurrent respiratory infections, where he had been treated with very multiple courses of antibiotics, and it have affected his quality of life. So I think we could get this presentation of B cell antibody defects as the presentation in allergies also, and we need to keep in mind the red flag signs. So in CVID, I think it is mainly the common respiratory and the enteroviruses which cause predominantly the infection susceptibility, and they could have bronchiectasis, giardias, autoimmunity also in 20% of them, asthma in 10% of them, and mainly the treatment would be covered in the next talk. But I think it is a very common presentation, and we need to keep an eye out for it. So case 2, this was another child who was about in the first year of life. And this child had a full-term uneventful neonatal course. However, by the end of his first month, the child developed dermatitis. The child also has intermittent colic and regurgitation. Along with this, the child has failure to thrive, diffuse lymphadenopathy. The child was clinically diagnosed as eczema, and because of the underlying colic and regurgitation, a probable diagnosis of cow's milk protein allergy was also suspected, because in about 30% of our patients with colic and with a strong family history of atopy, we do consider cow's milk protein allergy, and we give them an elimination diet, because at this point of time, we wouldn't be probably able to offer them an allergy evaluation. So elimination diet was considered in this child, and started on cow's milk free diet in the mother as well, while continuing on breastfeeding. However, they say that the child was partially better, but dermatitis remained still their concern, and this child was referred for probable food allergies. The main red flag signs I feel in this patient was the failure to thrive and the presence of diffuse lymphadenopathy, which is a little uncommon in this age group. So I think it was not, the dermatitis probably was not very typical of atopic dermatitis. The distribution we see in the infancy, predominantly it was more of chronic dermatitis, which is unfair. I mean, not very commonly seen in such early presentations. And the subsequent workup showed IgG reduced, IgA and IgM subclasses were definitely reduced. The absolute eosinophil count was 900 cells, which was less. And the helper and the T cells were about 61 and 20%. CD19 was 1%. And the T cells were of host origin and oligoclonal. So mainly a diagnosis of Omenn syndrome was considered, And cyclosporin. So this child was referred to one of my pediatric hemato-oncology colleagues at Narayan Vidyalaya in Bangalore. And the cyclosporin therapy was started. Haploidentical BMT from father and a 4-month stay. I think post-transplant, they had some complications like autoimmune hemolytic anemia, thrombocytopenia. Eventually, bone marrow boost was received from the father, now doing quite well, and with mild chronic colitis. So I think the other spectrum, what we see in allergy is the skin issues, I think, which we commonly mistaken it to be as an allergic disorder. So I think we have to again keep the red flag signs in consideration if we are dealing with an overlapping allergy or an inborn error of immunity. So SCID was highlighted in my earlier colleague's talk as well. So I think infection susceptibility here, all live vaccines and opportunistic infections and very early in life, and failure to thrive, chronic diarrhea, erythroderma or other skin eruptions could be very commonly seen. Inheritance could be X-linked or autosomal recessive, and mainly lymphopenia in most, diminished or T cell cells would be absent or very poor in vitro mitigen-induced T cell proliferation if we do it. So coming to case 3, this was a 15-month-old male child with respiratory distress. First episode treated as bronchiolitis at 9 months of age. The child was treated on nebulizations and the child got better. Subsequently, the child had another episode of respiratory infection, was not documented whether it was pneumonia, but it was treated as wheeze-associated respiratory infection with mainly multi-dose inhalers. A third episode, I think, where the child required hospitalization was quite severe. The chest X-ray had whiteout lung, what we say on the right side. I'm sorry, I couldn't get the X-ray of that, the X-ray picture. However, the child was unresponsive to antibiotics. At this point of time, the child underwent a CT scan where an abscess was detected, and the bowel showed hyphae on the bowel lavage. So this child underwent a DHR mainly for possibility evaluation of a phagocyte defect for the neutrophil oxidative burst, where we see that this was predominantly absent on the patient's DHR. So in patients who present with chronic granulomatous disease, as Dr. Vignesh was also highlighting in one of his cases, I think these patients present with recurrent infections, granulomas of the skin, liver, different organs involvement, granulomas. And basically right now, CGD is detected by the flow cytometry using dihydrorhodamine, and many of the peripheral labs do DHR, or as Dr. Umair was highlighting, I think even samples sent to the National Institute of Hematology, very good referral system and very prompt with the reports as well. So I think it has become easier to offer these advanced tests for suspected patients with IEI. The next couple of cases, it's courtesy Dr. Pooja Malia from the hemat-oncology team in NH, where I work closely with them. So 10-month-old child, he was the first born of 3rd-degree consanguineous marriage, born by full-term normal vaginal delivery, and he had no NICU admission. However, this child had cow's milk protein allergy under my follow-up. Unremarkable until about 4 months of age, when he was started on formula and developed the colic and blood on stools on introduction of the cow's milk formula, where we withheld and he was doing quite well. He had a few episodes of recurrent cold cough, where he was treated locally at 6 or 8 months of age, about 2 episodes where he got better. 1 episode required an antibiotic use. They stay in one of the northern Karnataka districts. But in about 10 months of age, where he had cough and cold and went to a local hospital, which was not, he was not getting better. and he had history of fever, and the local blood tests were done, where remarkably the total count was 64,000, and platelets were 3.68 lakhs. He was treated as sepsis with recurrent lower respiratory infection. However, he was referred to a government hospital further on for the management because the cough was not settling. He was noted to have hepatosplenomegaly, and there the peripheral smear showed leukemoid reaction with anemia, and direct Coombs test was negative. He was the bone marrow done there was showed hypercellular marrow with increased myelocyte series, suggestive of leukemoid reaction, where he was further referred on for to rule out malignancy. So at NH, where the peripheral smear was also suggestive of myeloid leukemoid reaction, and the bone marrow aspiration showed active erythropoiesis, myelopoiesis with no other significant abnormality. This child underwent the leukocyte adhesion defects flow cytometry, which was supposed to be normal. And as highlighted earlier in the laboratory diagnosis, the basic ferritin, iron, and iron binding capacity was done, which showed which was significantly low, and he was started on oral iron therapy. And clinical exome was positive for leukocyte adhesion deficiency type 3. So this child is planned for further management, and this was the genetic testing which was positive for this child. So I think as much as allergies can exist in a patient, we can also get multiple variation in the same patient, and it could be overlapping with autoimmunity or malignancy. So I think we should keep in mind, as has been highlighted by various speakers earlier as well. So my last case, I think full term, this was a 6-year-old boy, unsignificant birth history, but has had history of infection, say at 1.5 months, had otitis media, required antibiotics, 6 months, had an inguinal abscess, required prolonged antibiotics, again had meningitis at 9 months of age, and at 1 year had developed aspiration pneumonia requiring hospitalization. This child was actually referred in the possibility of an allergies as recurrent respiratory and ear issues were persisting and referred. But I think this child evaluated on the terms of IEI showed that NBT showed absent dye reduction as in one of my earlier patients, and was diagnosed to have chronic granulomatous disease, homozygous mutation of NFC gene, underwent haploidentical transplant with mother as the donor, and the child is thriving well. So vaccinations, I think, as highlighted, we have to avoid live virus vaccines, and sometimes post-vaccination, if we do not follow, or we are not aware of the family history, as was being asked in one of the questions in the chat box, the children can develop BCG adenitis, and this was one of our patients who had developed this BCG adenitis post BCG vaccination, and probably we should think about MSMD as one of the differentials as well. So in a nutshell, I think we should have an eye index of suspicion. As practicing allergists, it may not be a pure allergy issue we would be dealing with. Always consider the warning signs. Do a basic workup, which could be definitely done in most of the laboratories, and then refer to a immunodeficiency clinic nearby where the patient would be taken well care of. So thank you. Thank you for a very patient hearing.
Thank you, Dr. Soumya. So we'll now move on to the next speaker, who happens to be Dr. Stalin. Dr. Stalin is a senior consultant in the Department of Pediatric Hematology, Oncology, and Bone Marrow Transplant at the Aster CMI Hospital, Bangalore. He has done a lot of pediatric bone marrow transplants, including those for patients with inborn errors of immunity. So I would now like to invite Dr. Stalin to give his talk on treatment of inborn errors of immunity, especially hematopoietic stem cell transplant in these patients.
Thank you very much, sir, for the kind introduction. And I would like to thank the organizers, Dr. Manas and Dr. Neeraj Gupta, for giving me this opportunity. The first immunodeficiency was described in a young boy with multiple infections, but Bruton and Tall in 1952. With that, a new specialty was born. So as we heard already, from that time to current situation, there is more than 500 primary immunodeficiencies, and we talked about the classifications, and then the number of new diseases which is being described as every year passes on.
Dr. Stalin, we can't see your slides.
Oh, sorry. One second.
It is visible, sir?
It's visible, sir.
No, I don't know if there's some problem with my end, then I think I can't see them. Okay.
So is it okay?
Yes, sir. It's visible, sir.
Fine. Okay, thanks.
Visible.
So coming to the management of the PID, as you heard before, it has got myriad clinical presentations and manifestations, and the different manifestations can predominate in different patients. So the treatment is not going to be the same. In the interest of time, I'm going to stick to the general principles rather than going to each individual disorder, and I might quote some disorders as examples as I go along. So the treatment can be divided into supportive care and definitive treatment. In terms of supportive care, it's usually led by the clinical immunologist with the help of all the other specialists, depending on what is the system which is dominating. And to start the supportive care, you don't need a genetic diagnosis to initiate the treatment. And most of the time, the clinical picture and the laboratory findings which are consistent or suggestive of inborn errors of immunity is sufficient. In terms of general measures in supportive care, often we go ahead with the infection prophylaxis, which will include antifungal, antibacterial, and PCP prophylaxis. The antifungal prophylaxis, especially if the T cell or neutropenic defects, and the PCP prophylaxis if there is lymphocyte dysfunction. And one thing to consider in terms of severe immunodeficiencies, if you are suspecting, is whatever the blood product you are going to give, better they be irradiated in order to avoid transfusion-induced severe graft versus host disease. And vaccination schedule has to be adjusted and to avoid all the live vaccinations as it is being suggested already. In terms of specific scenarios, in conservative management, IV immunoglobulin replacement is quite widely used, especially in SCID, SID, and antibody deficiency disorders. If you are suspecting a severe combined immunodeficiency and we don't know the CMD status of the mother, it is better to avoid breastfeeding initially, at least until you know clearly what you are dealing with. And as the complications and problems can evolve over time, so sort of watching for morbidities and evolution of autoimmune, inflammatory, and malignancies is important. And immunosuppression and immunomodulation therapy may be needed depending on significant allergy or autoimmune manifestations. And if the genetic diagnosis is known, and if the pathway is clear, then sometimes small molecule inhibitors like JAK inhibitors or biological therapies and immunomodulated therapies and sometimes enzyme replacement therapies are used. And in general management of these patients, need for aggressive investigations to actively seek for infections and then clearing them is important because small infections can aggravate and then can become life-threatening. So the abscess has to be drained, and the disseminated BCG has to be treated accordingly, and atypical mycobacterial infection, fungal infection, and viral infections has to be treated. Sometimes malignancy may be the initial presentation of a primary immunodeficiencies. In terms of definitive treatment, as of now, the hematopoietic stem cell transplant forms one of the major definitive treatment of severe cellular immunodeficiencies. So if you look at the history of the transplant, the first transplant was done in 1956, but the real first allogenic human transplant happened in a primary immunodeficiency in 1968. The first transplant was between two twins. One of the twin had leukemia. So for that, who was considered the father of transplant, Don Thomas, received the Nobel Prize. And this is the first report of the first ever human allogenic transplant, which was done in a SCID child boy who had lost almost 11 members of his male side of the family. And it was done under the guidance of Dr. Robert Good, who was the immunologist. So he stayed in the hospital for 4 months and then discharged and then lived healthily. So before embarking on the transplant journey, we need to make an accurate diagnosis, because sometimes the diseases look similar, we can get it wrong. And the need for good pediatric immunologist is essential in order to navigate through this diagnostic landmine. And another important thing is the patients are often in a bad shape. So as much as possible, we need to get the patient into a good shape in terms of controlling all the infections. If they are in a very poor nutritional status, we need to try to improve the nutrition prior to transplant, provided that some time is allowed. Sometimes it may not be possible. And genetic testing, as Dr. Umair has already pointed out, has significantly improved. The wide availability of NGS has made an enormous difference in terms of our ability to diagnose and treat these conditions. But one word of caution, to just quote some examples, we had 2 patients where the patient had a primary inborn error of immunity, and the sibling who were considered as a donor had the same genetic mutation, which we figured out only while we are working up the donor. So this is a clear example. Just because you have got this genetic mutation doesn't automatically mean that the patient is going to be affected. So obviously we could not use those donors, but that is just a caution, because you just not have the gene defect, but also you need to have the clinical manifestation. So who should we transplant? So I will give some 3 scenarios: a 4-year-old boy with X-linked A-gamma globulinemia with a matched sibling, 12-year-old with X-linked hyper IgM on regular IVIG infusions and is doing well, and a 25-year-old homozygous perforin mutation with the first episode of HLH. So the first one, most people will definitely say this doesn't need a transplant, and the other 2, transplant should be considered, but it is not very straightforward decisions. So when you consider about the HSCT in inborn errors of immunity, some conditions it is curative. For example, in SCID, CGD, LAD1, CD40 ligand, DOC8, and CTLA4. But there are some situations it is really controversial. So which is on your right-hand side of the last column. But there are somewhere in between, there are patients who will improve, but it may not be completely cure the clinical phenotype. So the inborn error of immunity falls in a spectrum. One end of the spectrum, transplant is not generally indicated. In other end of the spectrum, it is definitely indicated, but a good chunk of patients will fall in between. So we have to make an individual decision on these patients based on the genetic diagnosis and also based on their clinical phenotype, because 2 people with the same genetic diagnosis or disease diagnosis may have very different phenotype. So what do we consider before doing a transplant? So generally, we tend to think in terms of SCID and non-SCID, because SCID patients generally are candidates for transplant, and quicker we proceed with the transplant, it is better. In non-SCID transplant, it is not that clear. So we need to weigh the pros and cons of transplant versus no transplant. The transplant, however well done and how much ever experienced the center is and the doctor is, still there is an inherent risk with the procedure, and there is a risk of mortality or long-term morbidity. So that has to be weighed against what would have happened to the patient without the transplant. The clinical status of the patient is important, and the timing, and especially in a country like ours, the financial status plays a crucial role, even though the transplant is considered an expensive procedure. But conservative management with expensive medication lifelong is not an option for majority of the patients. So some of the conditions where in the West can be managed without a transplant will become an indication for transplant in our setting. And also it also depends on what is the healthcare setting available, and the immunodeficiency is part of the multi-system disorder in those syndromic conditions where you are only correcting one bit of the problem and all the other problems remain. So generally speaking, to put it in a nutshell, any condition of inborn error of immunity which is due to a cellular defect which cannot be easily improved or corrected by medication administered externally is an indication for transplant. So those who are not too familiar with the transplant setting, so transplant risk will vary based on the who is the donor. So we have got matched sibling, which is considered as the gold standard, and then matched unrelated and haploidentical. How we source the stem cells, bone marrow, peripheral blood, cord, and what we collect from the donor and infuse to the patient is the graft. And then the preparatory regimen before we infuse the stem cells is what is called as a conditioning, which will often involve a component of reducing the bone marrow stem cells of the recipient, which we call myeloablation, and then some degree of immunosuppression. So if the intensity is quite severe, then we consider some myeloablative, and then reduced toxicity and reduced intensity in the decreasing order of intensity of the conditioning. And nowadays, the most recent advances has been the improvement in the haploidentical transplant, where half-match transplant are done, so which now significantly increase the donor pool, because now almost every patient will have a donor. So that can be done with removing the T cells, which we call as a T cell deplete, or with the T cells, which is T cell replete. So for the T cell replete transplant, the commonly used procedure is the post-transplant cyclophosphamide, where you give the cyclophosphamide on day 3 and day 4 after the infusion of stem cells, where the T cells which are exposed to the antigen, both the recipient and the donor, will proliferate. And at the peak of the proliferation is on day 3 and day 4, and you give the cyclophosphamide. It either eliminates or makes them anergic, so that you avoid the most important complications of haploidentical transplant, which is GVHD and rejection. So let us take some common scenarios. In terms of SCID transplants, the historical outcomes has been improving, but you can see that there is a huge difference between the matched sibling, matched unrelated, and haploidentical transplants. But in the modern era, with the current technology, these differences almost disappeared. So the outcomes are similar irrespective of which donor is used. And in our setting, even with post-transplant cyclophosphamide, we were able to give very good results. In one multi-center study from India, looking at the historical outcomes, the outcome was about 50%. But you may think 50% is bad, but this is now the results would have been much better. But it is the kind of patients who come to us not in a very good shape compared to the Western countries. That is the reason. And previously, it was considered that for SCID transplant, we don't need to give conditioning. But then later we learned that without conditioning, the immune reconstitution is quite poor, which then results in poor long-term outcomes. So nowadays, everybody agrees that even SCID patients will need some degree of conditioning. So this is one of our RAG2 deficiency patients who got transplanted and who is doing well. So going to the non-SCID patients, similarly, again, over time, the results have improved, but then you can see that there has been a long, significant difference in terms of who is the donor and what has been the outcome. But this has to be compared in terms of what has been the natural course of the disease without the transplant. For example, in a large study with CGD survival over a long time, you can see that the outcome is about 50% by the age of 25 years. So 50% mortality by 25 years. So from an Indian study, you can see that even the outcomes are significantly varying based on whether there is an autosomal recessive CGD or X-linked CGD. You compare that with the graphs on the right-hand side, which is a large study with 712 children with CGD who has been transplanted. And you can see the results are excellent. So this is one of our patients who had CGD, which we transplanted at 9 months of age. And that is a photograph father sent when he started school. So the question is, when is the good time to do the transplant? This is one of the landmark paper which was published where it was made it very clear that if the patients with SCID, immunodeficient patients who had either infection and more than 3.5 months at the time of transplant, their outcomes are very poor. The patients who had the best outcomes are the patients who are under 3.5 months and did not have infection at the time of transplant. So even with the haploidentical transplant, when we sort of compared the in inborn errors of immunity, whether you do a T cell deplete or T cell replete transplant, the outcomes have been good. The only category where the outcomes was not good is older children who had a T cell depleted transplant. And this poor outcome is primarily due to increased amount of viral infections, including adenovirus, CMV, and etc. Looking at the natural history of X-linked hyper IgM syndrome, again, you can see that the long-term outcome looks very, very poor. So if you see the top graph on the right-hand side, so that is, if you look at the first glance, it looks like transplant did not make any difference because that is the curves with and without transplant are completely overlapping. But if you see the graph at the bottom, if the transplant was done within 10 years of age, the outcome has been excellent. And whereas the outcomes are poor if you delay the transplant. So in essence, in most of the conditions with inborn errors of immunity, doing a transplant earlier is much better than doing it later. So for those who are not familiar with the transplant process, so we do the transplant process starts with after the donor patient workup, starting with a conditioning where we give the medications to reduce the stem bone marrow, create space for the new cells, and give immunosuppression, and then give the stem cell infusions after that. And then there is going to be a period where there is no output from the bone marrow, where the patient's stem cells are not working, the donor cells have not started working, and that is the most riskiest time of transplant. And then when the cell starts coming out, we call it the engraftment phase, and then post-engraftment period, we follow them up. So what is the best way to condition the patient is to give the least toxic regimen with the minimal and short and long-term side effects, but still achieve a cure for the underlying condition. So this is the same thing which the donor cells goes down and the recipient cells come up. More stronger conditioning you use, you will get a better chimerism, but at the same time, there is an increased risk of transplant-related mortality. And the immune cells which comes back after the transplant, they don't come all together. They come over a period of time in a staggered manner. The neutrophils and monocytes comes first, NK cells comes first, and then the CD4 cells comes later. The full B cell immunity takes quite a long time to come. So there has been a significant improvements in the transplant outcomes recently. There are a lot of reasons for that. One is the earlier diagnosis, and we have a very detailed graft selection hierarchy and superior HLA matching technology and improved supportive care and very vigilant infection surveillance and preemptive treatment and most effective antimicrobial therapy. And even further newer developments, the graft engineering has made a big difference where we can select out the cells what we want and remove the cells we don't want and give a more optimal outcome. And additional cellular therapy like memory cell infusions, and we can measure the drug levels so that we reduce the toxicity of the medication, but at the same time give the best sort of conditioning regimen without increasing the toxicity, and better cell dose grafts, and then sort of patient-tailored conditioning regimen. So all these things have made a huge difference in terms of outcomes. In terms of the drugs which are used in the transplant conditioning, so there is varying intensity. Originally, when people started doing transplant for inborn errors of immunity, myeloablative condition was predominantly used, but you can see that the outcomes have been quite poor in 50% range. So now, most of the time, we use sort of reduced toxicity conditioning because you don't need to sort of completely eliminate the host situation unless in few conditions where sort of coexistence of donor and recipient is sufficient to cure most of these disorders. So who should be the donor? Previously, we used to consider who is the donor as one of the main criteria for doing transplant. With the current setting, we don't need to worry about it. So we just go, if there is a matched sibling, we use a matched sibling. If there is no matched sibling, we may go for a matched unrelated donor. If that cannot be available quickly, we go for a haploidentical donor. So the donor does not decide whether a patient needs a transplant or not. It is mostly decided by the disease status and what is the indication for transplant. And important to say that the donor has got minimal risks unless any other transplant, say kidney transplant, liver transplant, the bone marrow donation or stem cell donation is very, very low risk for the donor. So it is quite easily doable. So that is often the question of most of the families. So in summary, careful consideration of the disease severity and long-term outcome without transplant has to be weighed against the risks of transplant and long-term risks of transplant. On many occasions, it has to be an individual decision, whether the family goes for transplant or not. Earlier, the transplant is better. And we need to remember that syndromic inborn errors of immunity may not correct the non-immunological manifestations of the condition. Just one last slide on the gene therapy. So gene therapy is improving But as far as inborn errors of immunity is concerned, probably ADS kit is the only situation where has got a proven role. In other conditions, especially X-linked kit was and CGD, it is being tried. Trials are being done, but it has not come as a standard practice yet. But in the future, it may come. But the problem is the cost of these is really prohibitive, and I don't see that coming to our country very soon, whereas the transplant outcomes are really improving. Thank you very much for the opportunity. I'm happy to answer any questions.
Thank you, Stalin, for such a wonderful presentation on this complex topic, and you made it very simple. I now request Dr. Amit Rawat to please take forward the Q&A session.
So I think some of the questions have been answered in the chat already. Like there was one question on a BCG adenitis in a child with IFN gamma R2 defect. So one of the participants asked whether they can give that vaccine or not. I think that has been answered. There was a first question on HLH in H syndrome. We got it deleted. I can't see that in my chat now.
Yeah, it is there. Treatment of hemophagocytosis plus H syndrome, SLC29 plus
That is the
syndrome.
gene that is the gene associated with H syndrome. So he has asked any a specific treatment required for that. I don't think there is any specific treatment. You would do what you do for other kinds of HLH, I guess.
Yeah.
Any other questions? Any participant would like to ask any questions?
So H syndrome, just a point I want to add, the spectrum can be varied. It's not that all children, they have histiocytic infiltrates. There can be antibody deficiency. There can be early onset type 1 diabetes. So autoimmunity, hyperinflammation, antibody deficiency, it's all part of this defect.
There's one more question in the chat, I guess. Can we differentiate leukoid reaction and leukemia from flow cytometry?
We can definitely do that. Leukemia reaction would just be, increased amount of neutrophilic infiltrate, just a response to some kind of infection, and you will have very high TLC neutrophilic response. Whereas leukemia mainly will have these cells in the blast region in the flow cytometry. First of all, I think we can differentiate it even by doing a peripheral smear examination, by doing a bone marrow examination. And then the next step is flow cytometry, where we can actually characterize the type of leukemia. So yes, it is definitely possible. And you need a good lab that can, look at peripheral smear, marrow, and then flow cytometry.
There was one question on whether we can work for an underlying IEI in the face of a severe infection. That's always a question that is asked to us, like, how reliable is your, immune analysis in the face of infection? So the way to go about it is that, in a severe, in a emergency like SCID, that might be the only opportunity to test for underlying IEI, because if you don't do that, the child may not survive, and then you may not able to, if you don't make the diagnosis in the index patient, you might not be able to help the family if they are planning for subsequent pregnancy, or they want a healthy child. So I think that opportunities should not be missed, but you have to bear in mind that in some cases of severe sepsis, there might be a lymphopenia which might be improve after the severe infection has gone. So that would be a one situation you should keep in mind. But by and large, I think basic investigations you should do even in the face of severe infection.
Neeraj, if there are no more questions, I think, we'll just request you to take the final marks and, conclude the session.
Thank you, everyone. And I would like to request Dr. Krishna Mohan to please give a vote of thanks.
Okay, thank you, Neeraj. Am I audible?
Yes, you're audible. You're audible.
Okay, so first and foremost, let me thank the allergy chapter, allergy and epidemiology chapter, especially the chairperson, for bringing this wonderful initiative, a mega CME on primary immunodeficiency diseases and its relation with allergy. So I also thank our partners in this program, the Indian Society for Pediatric Immunodeficiency and the IAP Pediatric Hematology and Oncology chapter for their wonderful contribution. And especially special thanks to the moderators, Dr. Manas Kalra and Dr. Amit Rawat, and today's wonderful faculties who delivered excellent lectures on all the topics, and also to the delegates who have joined in large numbers. So thank you so much. And also special thanks to the technical team for providing us the Zoom all this season. So thank you once again. Thank you.